Hello, friends. Welcome you all here at Traumacon 2024. What we are going to discuss now about the novel technique of fixation of the distal radius fractures. In the part one, we'll be discussing about why we need any alternative possibility of novel technique. What are the pitfalls and what are the problems and what are the solutions? And in part two, we'll discuss one of alternative technique step by step, how to do it as an alternative possibility. We know that there are multiple controversial issues with this part area. There is a spectrum of the methods with increasing complexity and the cost. To achieve the goal, anatomy is must. That is the question. Let us see one example. Let me ask you, suppose this is your patient. What will you do? Routinely, I get the answer from the audience that the splitting has to be done. And surgeon did same thing and checked intraarticular reduction, and the audience has agreed. After 9 years, what do you think? X-ray is bad, but the function is good, and the patient is happy with the end game parameters. Under the case, conservatively treated, what do you feel about the reduction? Everybody said that it has to be revised and it has to be fixed. Patient was treated conservatively, and after 10 years, X-ray is bad, but the function is good. Patient is happy. There is a benchmark paper in JBGS by Jupiter et al. In 1986 suggesting that anatomy is must. But again, same authors in 2009, anatomy is not must as far as the clinical function is considered. Another article, even among the highly active elderly, further study in the young, anatomy is not must. Functional outcome is same in both. Systemic reviews. For each method, RCTs were done with the systemic reviews, and the complications and reoperation rate was seen 11% in the wall plate. We all do routinely wall plates. Further study showing the complications, number of complications as we see day to day. So new toys with increased cost is coming in the market regularly and increased complications. So thought process was going on. Is there any low cost alternative possibility to fix each column in the line of the load exactly as similar to the proximal femur trabecular pattern as you compare with the proximal femur? So in part two, we are going to discuss novel technique of the fragment specific fixation with augmentation. Let us see how we do step by step. The first step is hematoma or the wrist block with xylocaine adrenaline. It is given in 3 parts here, you can see here. And once you give this and wait for 15 minutes, patient becomes painless. As you can see here, try to manipulate and see. It has become painless. You can see the face of the patient. Consent is already taken. Step 2 is reduction under C-arm. Once satisfied with the reduction, step 3 is the stab incision with the first radial column fixation to pass first wire volar radial to dorsal medial cortex for fixation of the radial column. This is the trajectory of the wire. That has to be kept in the mind. Second wire is going through the dorsal ulnar to volar lateral cortex. That is the trajectory for a intermediate column fixation. Then exactly bending of the wire. Just see it. I'm trying to bend the wires. Exactly. And once these wires are bent, it gives a good fixation, and further augmentation of the fixation is done by linking these wires. They are not alone. Now they are united. United has a strength, and this will get augmented automatically with the link joints. You can see here very well. One rod, then the second rod. Two rods has been fixed here. Once this fixation is done, the extra wire has been cut and the very good padded dressing has been put, and the slab, plaster slab is applied to reduce the edema for the first 2 weeks. Once the patient is painless, this plaster slab is kept just to support to reduce the edema. As it is in the block, before applying the plaster slab, you can check it very well, all the movements for the stability in all the planes on the C-arm. You can see here. And the patient walks out with happy face and feeling. Surgeon is having a flexibility to pass the wires according to the fracture patterns. It can be passed wherever direction, wherever the fracture plane is there. So surgeon has to decide the trajectory of the wires according to the plane of the fractures and the columns. Someone asked me, can we fix the scaphoid punch fragment with this? Yes. We can elevate that fragment and further raft it through by the K wires and further supported with the augmentation with the link joints, and that will give rise to very good fixation. You can see here all the columns, 3 columns are fixed. Even ulnar column was fractured. So radial, intermediate, and the ulnar column. All 3 wires, 4 wires as needed. Sometimes we go intramedullary to get the longer fixation, and then it gets stabilized by augmentation with the link joint. Linking is a very important thing. In an economically compromised patient, there was also a question, can we treat the volobarton? I usually treat the volobarton with the plate. But this can also be done. Taking care by putting a stab incision, putting an artery, reaching to the bone, taking care of the neurovascular bundle from the volar aspect, and you can pass the wire from the volar aspect. Or if it is a dorsal fragment, you can pass the from the dorsal aspect. And that is again linked in a different direction. Another patient, same steps, it's a versatile method. It can be done at any district hospitals with even less facility for such a economically compromised patients. And it gives very good stability, which can be checked on the table. And it's a daycare procedure. So message is, for each column, fixation has to be done, and the radiology and function may not correlate. Need to identify the fracture planes and trajectory of the pins in that particular plane, and then augmentation gives the stability and gives the columnar stability with the cost effectiveness. I bow down to you for your kind listening and love and support. Thank you. We welcome you for Traumacon 2025.